Good afternoon. My name's Hannah, and today I will be presenting my Doctor of Nursing Practice scholarly project titled Breast Cancer Screening Education for Improved Compliance. The purpose of today's presentation is to share the development, implementation, and outcomes of a quality improvement initiative designed to evaluate whether a brief, standardized educational intervention could improve breast cancer screening adherence among women who are overdue for mammograms. Throughout the presentation, I'll discuss the clinical problem that inspired the project, the evidence supporting the intervention, the methods used to implement it, and the project results and the implications for advanced nursing practice. Breast cancer remains one of the most significant public health concerns affecting women and is currently the most commonly diagnosed cancer among women in the U.S. Although advances in screening and treatment have significantly improved survival, early detection through routine mammogram remains essential to achieving these outcomes. Currently, approximately 79.8% of eligible women are up to date on breast cancer screening, which falls just below the Healthy People 2030 target of 80.3%. While that difference appears small, it represents millions of women nationwide who remain overdue for recommended screening. Research has identified several common barriers to screening, including limited knowledge of current recommendation, fear of receiving a cancer diagnosis, financial concerns, transportation challenges, and a lack of provider recommendation. As advanced practice nurses, we have frequent opportunities to address many of these barriers through patient education. Because provider recommendation consistently predicts screening participation, I wanted to evaluate whether a brief educational intervention delivered during a routine office visit could positively influence screening behavior. That question ultimately became the foundation of this project. The purpose of this quality improvement project was to determine whether providing standardized breast cancer education during routine primary care visits could improve mammogram adherence among women who were overdue for screening. The intervention consisted of 3 components. Participants first received a brief standardized verbal education session based on current American Cancer Society recommendations. They were then provided with an American Cancer Society breast cancer educational handout and fact sheet, following by a locally developed resource guide identifying affordable mammogram facilities within the community. The project was guided by the following PICO question. Among women ages 40 to 70 who are overdue for breast cancer screening, does a standardized educational intervention improve mammogram completion or intent to complete screening within 6 months when compared with current national screening rates? Ultimately, the goal of this project was not only to improve screening adherence, but also to promote earlier breast cancer detection through a practical intervention that could easily be incorporated into everyday clinical practice. Before implementing the project, I completed a comprehensive review of current literature to identify evidence supporting breast cancer screening education. 4 major themes consistently emerged. First, routine mammogram remains one of the most effective methods for reducing breast cancer mortality through early detection. Second, barriers such as fear, misinformation, financial limitations, and lack of provider recommendation continues to prevent many women from participating in the recommended screenings. Third, multiple studies demonstrated that structured educational interventions improve patient knowledge and increase participation in mammogram screening. Finally, the literature emphasized that education is most effective when it is simple, culturally appropriate, and paired with practical community resources that reduce those barriers to care. Overall, the literature strongly supported implementing a standardized educational intervention within primary care and provided the evidence base for this quality improvement project. This project was guided by Pender's health promotion model, which emphasized the role of individual beliefs and perceived barriers in influencing health behaviors. I selected this framework because breast cancer screening is a preventative health behavior that requires patients to recognize the benefits of screening while overcoming barriers that may prevent them from taking action. The educational intervention was intentionally designed to address these concepts. The verbal education and written materials increased patient knowledge regarding breast cancer and the benefits of early detection, while the local resource guide addressed practical barriers related to cost and to travel. Using Pender's model reinforced the idea that education is more than simply providing information. It's about empowering patients to make informed decisions and increasing their confidence to participate in recommended preventative care. For that reason, the health promotion model provided an appropriate theoretical foundation for both the intervention and the anticipated behavioral outcomes. This project utilized a prospective, single-group, post-intervention quality improvement design conducted within a functional wellness primary clinic in the Pacific Northwest. A quality improvement design was selected because the primary goal was to evaluate an evidence-based practice change within a real clinical setting rather than establish cause and effect relationships. Instead of testing an experimental treatment, this project focused on improving an existing clinical process through standardized patient education. Because every participant enrolled in the project was already overdue for breast cancer screening, all participants entered within the same baseline condition of non-compliance. Rather than comparing two groups, outcomes following the intervention were compared with the current national breast cancer screening benchmark. This design also fit naturally into routine clinical workflow. The intervention required minimal additional time during the scheduled patient visits, making it practical, sustainable, and easily replicated for future practice. The project included 48 women between the ages of 40 and 70 who were established patients within the participating primary care clinic. Participants were eligible if they were overdue for breast cancer screening, English speaking, able to provide informed consent, and willing to participate in the educational intervention. Women were excluded if they had recently completed a mammogram, had a personal history of breast cancer, were outside the target age range, or declined participation. One strength of the sample was that every participant represented the exact population the project was designed to address. Since all women were already overdue for screening, the intervention specifically targeted patients with the greatest opportunity for improvement. The intervention itself was intentionally designed to be simple, standardized, and easy to incorporate into routine practice. After providing informed consent, each participant received a brief, standardized verbal educational session based on current American Cancer Society breast cancer screening recommendations. Participants then received an American Cancer Society educational handout reinforcing the verbal discussion, followed by a locally developed brochure listing nearby mammogram facilities, including reduced cost and sliding scale options whenever available. An important consideration during development of the intervention was health literacy. All educational materials were evaluated for readability to ensure they were appropriate for the target population. The verbal script was written at approximately an 8th grade reading level, while the written materials met recommended readability guidelines for patient education. The goal was to ensure that every participant received consistent, evidence-based information while also reducing common barriers related to access and affordability. Project outcomes were measured approximately 30 days after the educational intervention. Each participant received a follow-up telephone call using a standardized script and was asked whether she had completed a mammogram or intended to complete one within the following 6 months. Responses were recorded as either a yes or no within a secure, de-identified electronic database. This simple binary outcome was selected because the purpose of the project was to evaluate behavioral change rather than simply measure knowledge acquisition. By using a standardized follow-up process for every patient, consistency in data collection was maintained throughout the project. Following the data collection, both descriptive and inferential statistics were used to evaluate project outcomes. Descriptive statistics summarize the proportion of participants who reported completing or intending to complete breast cancer screening following the intervention. To compare these results with the national breast cancer screening benchmark of 79.8%, a 1 proportion z-test was performed. This statistical test was appropriate because the project evaluated a single sample within a binary outcome and compared the observed proportion to an established benchmark rather than to another intervention group. Statistical significance was evaluated using an alpha level of 0.05, meaning a p-value below 0.05 would indicate that the observed difference was unlikely to have occurred by chance. Following implementation of the educational intervention, 48 women completed the Quality Improvement Project. Of these participants, 39 women, representing 81.25%, reported that they had either completed a mammogram or intended to complete one within the following 6 months. The remaining 9 participants, or 18.75%, reported that they did not intend to complete screening during this time frame. These results were then compared to the current national benchmark for cancer screening, which was the 79.8%. Overall, the project demonstrated a post-intervention screening adherence rate of 81.25%, which exceeded the national benchmark by approximately 1.45 points. To determine whether this difference was statistically significant, a 1 proportion z-test was performed. The analysis produced a z-statistic of 0.2502 with a p-value of 0.4012. Because the p-value was greater than the predetermined alpha level of 0.05, the null hypothesis was not rejected, indicating that the observed improvement was not statistically significant. Although statistical significance was not achieved, I believe these findings remain clinically meaningful. First, it's important to remember the population included in this project. Every participant enrolled was already overdue for recommended breast cancer screening. These were women who had not been following current screening guidelines. Following only a brief educational intervention, more than 81% reported either completing or intending to complete mammogram within 6 months. From a clinical perspective, I believe this is an encouraging outcome. Another important consideration is the sample size. The difference between the project's screening rate of 81.25% and the national benchmark of 79.8% was relatively small. Detecting a difference of just over 1% point generally requires a much larger sample than the 48 participants included in this project. For that reason, I believe the lack of statistical significance is more reflective of limited statistical power than a lack of intervention effectiveness. The findings also aligned well with the literature reviewed earlier in this project. Previous studies consistently demonstrated the provider recommendation, structured education, and reducing barriers to care improve screening participation. My project demonstrated a similar positive trend within this clinical setting. Overall, these findings suggest that standardized patient education is a practical intervention that can be incorporated into routine primary care while encouraging preventative health behaviors among women who are overdue for breast cancer screening. Here are 2 different graphs that we used to describe the findings of this project, including post-intervention comparison of compliance rates, again, that 81.25% to the 18.75%, and then comparing the national average to the post-intervention findings on the second graph. When interpreting these findings, I think it's important to focus on what this project contributes to clinical practice. One of the greatest strengths of this intervention is its simplicity. The educational session required only a few additional minutes during a routine office visit, yet it provided patients with evidence-based information, written educational materials, and practical resources to help overcome common barriers to screening. This project also reinforces the important role healthcare providers play in preventative care. Throughout the literature, provider recommendations consistently emerged as one of the strongest predictors of mammogram adherence. My findings support that concept by demonstrating that even brief, standardized education may positively influence patients' decision making. While larger studies involving more participants would strengthen this evidence, I believe this project demonstrates that meaningful quality improvement initiatives do not always require complex or expensive interventions. Sometimes a simple evidence-based conversation can encourage patients to take an important step towards practicing and protecting their long-term health. As with any quality improvement project, several limitations should be considered when interpreting these findings. First, the project included a relatively small sample size of 48 participants. While this met the project's intended enrollment, it limited the statistical power needed to detect a relatively small difference between the project outcome and that national benchmark of 79.8%. Second, the project was conducted within a single functional wellness primary care clinic. Patients in this setting may already place a greater emphasis on preventative health care than the general population, which may limit the generalizability of the finding in other clinical settings. Another limitation was the use of participants' self-report during the 30-day follow-up phone call. While participants reported whether they had completed or intended to complete a mammogram, the project did not verify screening completion through any sort of a medical record review. Finally, because this was a quality improvement initiative rather than a randomized controlled trial, causation cannot be established. Other factors outside of the educational intervention may also have influenced the participants' decisions to pursue mammography screening. Recognizing these limitations provides valuable direction for future quality improvement initiatives while helping place the findings into the appropriate clinical context. Despite these limitations, I believe this project has several meaningful implications for advanced nursing practice. First, it demonstrates that standardized patient education can be incorporated into routine primary care with very little disruption to clinical workflow. Second, it reinforces the important role advanced practice nurses play in preventative healthcare. We are often the providers discussing screening recommendations, answering those patient questions, and helping patients overcome barriers that may prevent them from seeking care in the first place. Even brief educational conversations have the potential to influence patient decision-making and encourage participation in recommended preventative screenings. This project also supports broader public health initiatives, including the Healthy People 2030 objective of improving breast cancer screening adherence. Increasing participation in routine mammogram has the potential to improve early detection, reduce breast cancer mortality, and decrease healthcare costs associated with advanced stage disease. Ultimately, this project reinforces that patient education remains one of the simplest and most accessible evidence-based interventions available to advanced practice nurses in the primary care setting. In conclusion, this quality improvement project evaluated whether a brief, standardized educational intervention could improve breast cancer screening adherence among women who were overdue for mammogram. Following implementation, 39 of the 48 participants, or 81.25%, reported completing or intending to complete breast cancer screening within 6 months of the initial intervention, slightly exceeding the current national screening benchmark of 79.8%. Although the difference was not statistically significant, the project demonstrated a positive clinical trend while requiring minimal additional provider time or clinical resources. More importantly, it demonstrated that evidence-based patient education can be successfully integrated into routine primary care and has the potential to encourage preventative health behaviors. Future projects involving larger sample sizes, multiple clinical sites, and longer follow-up periods would help further evaluate the effectiveness of this intervention and strengthen the evidence supporting that implementation. Completing this Doctor of Nursing practice project has been one of the most meaningful experiences of my career as a student. Throughout this program, I've learned that evidence-based practice extends far beyond reviewing research articles. It involves identifying opportunities for improvement, implementing evidence-based interventions, evaluating outcomes, and continuously refining clinical practice. This project strengthens my ability to critically evaluate literature, interpret data, and translate evidence into meaningful practice change. Perhaps most importantly, it reinforced the quality improvement does not always require large-scale systemic changes. Sometimes meaningful improvement begins with simple, intentional conversations that empower patients to make informed decisions about their health. As I transition into practice as a nurse practitioner, I look forward to continuing to lead quality improvement initiatives that improve preventative care and patient outcomes. Based on the findings of this project, I would recommend continuing this intervention while expanding future quality improvement efforts. Future projects should include target populations that are larger, implementing project across multiple practice settings, and including longer follow-up periods with confirmation of mammogram completion through medical record review. Combining standardized education with additional strategies such as electronic health record reminders or patient navigation services may further improve screening adherence and should be considered in future initiatives as well. Before concluding, I'd like to sincerely thank my committee members for all of their guidance, mentorship, and support throughout this project. I would also like to thank my clinical site and every participant who contributed to this quality improvement initiative. Their support have made this accomplishment possible. In closing, this project demonstrated that a brief, standardized educational intervention may positively influence breast cancer screening adherence among women who are overdue for recommended mammography. While additional evaluation with larger populations is warranted, I believe these findings support the continued integration of evidence-based patient education into routine primary care practice. Thank you for your time, attention, and the opportunity to present my scholarly project today. I appreciate your consideration and would be happy to answer any questions. The next 2 slides are references used for this project completion. Thank you for your time.